So because of this weakening of the immune system, we are prone to develop certain infections at a higher frequency than during our younger age. If you look at herpes zoster, about which and the prevention of which I am going to discuss today, this is caused by the reactivation of the normal chickenpox or varicella zoster virus. Young age, most of us have suffered from chickenpox, at least people of my generation. Once you get chickenpox, the virus stays latent in the sensory ganglion of our nerves in any part of the body, and then subsequently, when the immune system becomes weak, this can reactivate to form herpes zoster. It has been seen that almost 99% of adults over the age of 40 years are, and there is an increased risk of 10 to 50%. Secondary bacterial infections occur in 4 to 20% of patients, and studies from India show that at advanced age, the occurrence of underlying HIV, diabetic mellitus, and prolonged steroid use or malignancy were frequent predisposing or comorbid conditions. If you look at patients who are immunocompromised, the occurrence of shingles is also seen much higher than people of similar age. For example, in the normal population, the occurrence is 5 per 1,000 person years. In patients with bone marrow stem cell transplant, it is as high as 43. If you look at systemic lupus erythematosus, it's 15, and if it is rheumatoid arthritis, it is 12.2. So this is a double whammy where, along with an increasing age, you also find that rheumatic and musculoskeletal diseases can be associated with an increased incidence of herpes zoster. The presentation of herpes zoster in immunocompromised patients is also more severe and long-lasting. The lesions are more numerous. They can present with a hemorrhagic base. The occurrence of herpes zoster is also multidermatomal, and there is a higher risk of developing complications, typically viremia, pneumonitis, disseminated zoster, meningoencephalitis, and the risk of post-herpetic neuralgia is also much higher. In the context of rheumatoid arthritis specifically, patients who are on disease-modifying agents have a much higher risk, whether it is monoclonal antibodies, co-stimulation modulators, IL-6 inhibitors, and specifically JAK inhibitors have a higher risk of developing herpes zoster. This specifically supports the use of herpes zoster vaccination for prevention of zoster. What about SLE? Again, compared to normal people of a similar age group, you find that the risk of developing herpes zoster is much higher in people with SLE in all age groups. Among people with SLE, the risk factor for herpes zoster include high dose of steroids or immunosuppressive therapy, older age, lymphopenia, and glomerulonephritis or other major organ diseases. So in general, people with rheumatic and musculoskeletal diseases who may be immunocompromised because of their medications are at a much higher risk of developing herpes zoster and its complication, especially with increasing age. To prevent this, till recently we had the live zoster vaccine, but unfortunately the live zoster vaccine cannot be given to people who are immunocompromised. So the recent newly available vaccine, which is going to be available in India, is the recombinant zoster vaccine. This comprises of an antigen and an adjuvant system, which is called AS01B, which enhances the immune response to the vaccination. The AS01 induces an activation of the innate immune response in the muscle, in the lymph node, and also leads to antibody production, which goes around in the circulation, thereby leading to a more robust immune response, which is long-lasting. So the advantages of this is very clear. This can be given for the immunocompromised person, and even in this population, it elicits a robust response. The pivotal studies were the ZOE 50 and the ZOE 70 studies, which were done in several centers in North America, Europe, Latin America, and Asia Pacific. And when you look at the vaccine efficacy, you will find that the overall efficacy in the over 50 to 70 population was anywhere in the region of 96 to 97.4%, and the vaccine efficacy in the older population was still very significant at over 91%. So this tells us this is a very effective vaccine. Does this vaccine help in both post-herpetic neuralgia and non-PHN complications across the age group? Yes, it does. the vaccine efficacy was again over 90% in most situations, except in the elderly over the age of 80, the efficacy was slightly lower. And this was seen also with other herpes zoster related complications, both over 50 and over 70 years of age. What was surprising and very reassuring is the fact that even during long-term follow-up, the efficacy remained very significant. So, in spite of vaccinating people over the age of 50 or 60, even when they reached another 10 years, and this was available for follow-up for almost 10 years, the vaccine efficacy remained very, very significant. What about local and systemic side effects? The side effects of this recombinant zoster vaccine is very, very mild. Apart from local pain, redness, swelling, fatigue, some GI symptoms, headache, myalgia, shivering, and fever in a small percentage of population, about 10%. And all these were a little more marked after the second dose than after the first dose. The efficacy and safety of this vaccine in participants with immune-modulated diseases was also very impressive. The efficacy was very, very robust. Generally over 90% in most situations, and even in patients with these immunomodulatory conditions, this side effect profile was very, very acceptable. Based on this, several countries have recommended the recombinant zoster vaccine in their national programs. Countries like the United States, Canada, Germany, UK, Ireland, Netherlands, and also other European countries like Spain, Czechoslovakia, Austria, Italy, and also Australia and Saudi Arabia. In India, the vaccine has been approved specifically only for the people above the age of 50 years. Studies are also available based on which several countries have recommended this vaccine for people above the age of 50 with immunomodulatory conditions. So, in patients with rheumatoid arthritis, the United States, Canada and Spain recommended even for people over the age of 18 or 19, whereas Germany, Switzerland and New Zealand recommend this above the age of 50 for people with rheumatoid arthritis. What about people with systemic lupus erythematosus? Again, this vaccine is recommended in younger people also who are at high risk of developing the herpes zoster infections and its complications, both due to the disease advancing age and because of the immunosuppressive medications. USA and Canada recommended for younger people, and Germany and New Zealand recommended for SLE, patients with SLE over the age of 50. So if you look at the summary, the autoimmune diseases are associated with a higher risk of developing rheumatoid arthritis and SLE. The incidence of herpes zoster and its complications in this population is because of the immune dysfunction and the medication which is typically immunosuppressive when treating these conditions. The immunosuppressive therapies used to treat these include glucocorticoids, disease-modifying agents, calcineurin inhibitors, TNF-alpha, interleukin, and JAK inhibitor classes. These are all associated with a higher occurrence of herpes zoster and its complications. Immunization is particularly important to reduce vaccine-preventable infections in patients with these conditions, especially those on immunosuppressive therapy, and the vaccination is recommended when they are stable before their immunosuppression increases. In spite of this, there is still a significantly unmet need for more data on the use of herpes zoster vaccination in this population, and the recombinant zoster vaccine has significant advantages over the live vaccine. The dosing schedule currently is 2 doses to be given in a span of the initial dose followed by the second dose after 1 to 6 months, and this vaccine hopefully.
We'll invite a second speaker, Dr. Pradeep Kumar Sharma from Guwahati, to speak on adult vaccinations in RMD patients who are receiving conventional synthetic treatments. Over to Dr. Pradeep.
Good evening, everyone. I hope it is worthwhile for everyone for staying back after a long day. So, as Sana has mentioned, COVID has actually generated interest in vaccine, but it is one of the probably most neglected subject in our specialty. So, So, vaccination for prevention of infection in rheumatological diseases are important because infections are more common in this group of diseases. Actually, they are 2 to 4 more common than the general population. Infection is common, that is one part, but mortality and morbidity both are increased in these rheumatological disorders. Patients with rheumatoid arthritis are 2 times more likely to die because of infection than the general populations. More than 1/3 of the patients of SLE or vasculitis die due to infections. And this risk of increased infection, mortality and morbidity is due to aberrant immune response in these diseases because of the drugs that we use and because of the comorbidities. And it has been seen that the use of corticosteroids increases the risk of infection in a dose-dependent manner. Just an example of this study from Stanford University, they had around 5 patients had infections needing around 700 odd times hospitalization, and as the age increases, the risk of infection increases. And every year, more than 1.5 million deaths occurs because of pneumonia due to Streptococcus pneumoniae or Haemophilus influenzae or respiratory syncytial viruses. And we can see that even in immunocompetent people, when patients have invasive pneumococcal disease like meningitis or septicemia, 37% of people are likely to die. If the patient has pneumonia because of these pneumococcal diseases, 21% is likely to die because of infection. So we can prevent this by vaccinations, but there is not much interest. Even I was actually not taking much of interest in vaccination till a few months back when I had to present a talk. Then only I read about vaccination in our diseases. So there are some small surveys. We can see that acceptance of influenza or pneumococcal vaccine is around 50%. Even in high-risk populations, coverage is hardly exceeds 30 to 40%. So awareness about vaccination is need of the hour, but in our diseases, there is concern about efficacy when patient is on the DMARDs, then whether it will be immunogenics or not, and what about safety of these vaccinations. So there are some studies, small scale studies. Problem in vaccination in rheumatological diseases is that there is not much good data actually, but there are small data. So this is from Spain. So what they actually decided that they will vaccinate their patients who are going to receive anti-TNF therapy. So their vaccination schedule was 1 dose of pneumococcal conjugate vaccine, followed by after 2 months that capsular polysaccharide vaccines, 3 doses of hepatitis B vaccines, 1 dose of tetanus diphtheria vaccine, 1 dose of influenza vaccine. And if the patient has other risk factors like complement deficiency or others, other vaccines like hepatitis A or meningococcus or Haemophilus vaccines were administered. So most of the patients, half of the patients were from rheumatology, other half was from gastroenterology. Half of the patients had inflammatory bowel disease. Rheumatoid arthritis was around 25%, 20% patients had psoriatic arthritis. Half of the patients received only anti-TNF therapy. Around 20% received steroids along with anti-TNF, and around 1/3 of the patients received anti-TNF and conventional DMARDs. Does vaccination protect from infection? The answer was yes. So before this vaccination program, only around 27% received vaccines, but after this vaccination this program, almost 97% before anti-TNF therapy received vaccination. And we can see that after vaccination, emergency visits was almost half. Then hospital admissions was for infections was reduced by around 1/3. Then hospital admission due to invasive pneumococcal disease was almost nil after vaccination. So vaccination protect from infection in our diseases. But there is not much robust data. So this is a systemic literature review done for that user recommendation. We can see that clinical efficacy about with vaccines actually there is not much data. But immunogenicity, yes. It is reduced with B-cell depletion for both influenza and pneumococcal. Hepatocyte, it is controversial, probably reduced. But for influenza, even with conventional or other biologics therapy, adequate immunogenicity is seen. But with methodological probably reduced immunogenicity is seen for pneumococcal vaccine. So with tocilizumab or high-dose glucocorticoids. So I am mostly concentrated on EULAR recommendations because that is the recent one, 2019. I also mentioned about the Indian recommendation published by Magadesar and his group. So inactivated vaccine, I also sometimes forget which are inactivated and which are live attenuated vaccines. So inactivated vaccines important are hepatitis A, hepatitis B, then human papillomavirus, influenza, then Streptococcus pneumoniae, tetanus toxoid. These are inactivated vaccines. So live attenuated vaccines are oral poliomyelitis, varicella zoster. Till now we will be having that inactivated vaccine recently as discussed by the previous speakers. Then oral typhoid fever and yellow fever. So these are live attenuated vaccines. So these are the overall things, principles from Euler. So vaccination status and indications for further vaccination should be assessed yearly in all patients. The individualized vaccination program should be explained to the patient so that a shared decision can be made between the patients and the caregiver. Vaccination should preferably be administered during the quiescent disease. We should avoid during active disease. Vaccination should preferably be administered prior to immunosuppression, especially if we are planning for B-cell depleting therapy. Non-live vaccines can be administered while the patient is on glucocorticoids and DMARDs, but live attenuated vaccines can be considered with caution. But there is level of agreement was less for live attenuated vaccines. Is quiescent disease at the time of vaccination absolute necessity? So there are some, there is a study with SLE patients who were vaccinated for influenza. Then when the patient has active disease, seroconversion was low. But in contrast to that, in another 340 patients of rheumatology vaccinated for influenza, seroconversion was good. So there is limited knowledge on the safety and immunogenicity of vaccinations in patients with active disease. So vaccination preferably should be administered during the quiescent disease. But if the patient has active disease, immunization should not be precluded and considered on individual basis. But live vaccination should be avoided when we are using immunosuppressions. So immunosuppressions, according to Euler, means prednisolone more than 20 mg for more 2 weeks or more, cyclosporin 2.5 mg per kg or per day, sulfasalazine 40 mg per kg per day, then methotrexate, azathioprine 3 mg more than 3 mg per kg, then leflunomide 0.5 mg per kg per day. So B-cell depletion therapy, we should avoid live vaccine at least for 6 months if the patient has received B-cell depletion therapy. But there are exceptions. There are few small studies from different countries like Netherlands or Germany or Brazil where patients with JIA or pediatric SLE were administered with measles vaccines. There was no measles were seen, immunogenicity was okay, and there was no flare of SLE or JIA patients. So measles virus booster vaccine can be considered in autoimmune rheumatic diseases on low-grade immunosuppression at risk of developing measles. Another exception is herpes zoster, because this was a study with patients with 60 years or more with autoimmune rheumatic diseases who were on immunosuppressive drugs, including biological DMARDs. They did not show any increase in incidence of herpes zoster for around 1.5 months. Another 10 patients on SLE who were administered herpes zoster vaccines. There was no zoster seen up till 3 months. So live attenuated herpes zoster may be considered in patients at risk. This vaccine is preferably administered prior to initiation of biological DMARDs or targeted synthetic DMARDs like Vaccination. Then pneumococcal vaccine. So Euler had recommended that every patient should receive pneumococcal vaccines. 2 doses, first is conjugate vaccine. After 2 months, then that polysaccharide vaccine is administered. So these are the difference between capsular polysaccharide and conjugate vaccine. I don't go into details because time is short. So mostly at this capsular polysaccharide memory is less, but in conjugate memory is more. So that's why for polysaccharide we need to give booster. In conjugate, no need for booster, single dose is sufficient. And with conjugate vaccine, there are trials that Kepidata published in NAGM that was in, not in rheumatological diseases, and there is good protection from this community-acquired pneumonia and invasive pneumococcal disease. But there are studies in rheumatological diseases also who were on etanercept, and there was good immunogenicity with pneumococcal vaccine. So this is the schedule for pneumococcal vaccine. If the patient is 9, we should first administer conjugate vaccine. Then after 2 months, we should give that this capsular polysaccharide vaccine. Then we should give the booster at 5 years. Then once the patient reaches 65, we should give another booster. So after 65, only 1 dose, no more doses is required. So if the patient received this capsular polysaccharide vaccine only, we should give conjugate vaccine only after 1 year. So after that, again booster is required after 5 years. Then if the patient received 1 dose of capsular polysaccharide and 1 dose of conjugate vaccine, we need to give only booster doses. Then the next vaccine is influenza, that is well versed with. So this is from Malave sir and his group. He has actually proposed that best time to vaccine for influenza is between April to May, except in temperate states like Kashmir or northern hilly areas or extreme south regions where it should be administered between September to October. Then hepatitis A, actually there is not much data, but it is believed that probably 1 dose is not sufficient for hepatitis A. Probably these patients who are on DMARDs, they probably need a second dose, or at least we should see the serum level of antibodies. Hepatitis B is similar like hepatitis A. There is no good data, efficacy data about hepatitis B, and even high dose vaccination actually does not increase the humoral response rate. So in high risk populations, we have to give hepatitis B vaccination, but if the patient receives B-cell depleting therapy, patient may need basic immunization. This is the vaccine, yellow fever vaccine, which should be avoided. Though there are small scale data which did not show any rise or any case, yellow fever case after vaccination, but still we should be cautious. Recommendation is that if the patient needs yellow fever vaccination, if it is absolutely necessary, then we have to stop the DMARDs. Then only we can vaccinate these patients. Then we should not forget the environment, household context, vaccination of household context should be always done. And one should always remember that oral polio vaccines in the kids, so that there is a risk of transmission if the patient is on immunosuppressions. That if an infant has received rotavirus vaccine, then the immunocompromised patient should not change the diapers. So these are the usual recommendations. All patients should receive influenza and pneumococcal vaccines. Tetanus toxoid, it is like that of immunocompetent individuals. Hepatitis and hepatitis B vaccination should be administered in patients with risk. Herpes zoster vaccination may be considered in high-risk patients. Then on human papillomavirus, SLE patients especially, they should receive these vaccinations. Then live attenuated vaccine should be avoided during the first 6 months of life in newborn mothers who were treated with biologics in the second half of pregnancy. So this is the proposed vaccination schedule in India proposed by Malave sir and his group. So patients, young patients in between 19 to 45, they should receive 3 doses of human papillomavirus. Then 50 to 64, 1 dose of this very herpes zoster. Then pneumococcus, as we have discussed, every year influenza vaccination should be done. Then hepatitis B, 3 doses should be given. Is temporary cessation of DMARDs necessary? So moderator is here. He has published one on with COVID vaccination. He will be actually knowing more about this temporary cessation of vaccinations. But what he has shown that if we withhold methotrexate even for a single dose, that is second dose, it is good enough for like that of withholding before both the doses. But there is a small risk of failure if we withhold methotrexate for both the doses. So this is the ACR guideline. I think everyone was versed with. I won't go into the details. So these are the vaccines available in India. So we have almost all the vaccines that we have discussed. Only the killed herpes zoster vaccines probably will be available recently. But problem is the cost. What we have discussed, if we go by that recommendation, so patient less than 65 years, it will cost around 20,000. Patients more than 65, it will cost around 14,000. And that excludes yearly influenza virus. So if you tell our patients, probably most of our patients will go away from vaccination. But for influenza and pneumonia, if we think about one admission costing in lakhs of rupees in our hospital, probably it is worthwhile. So to conclude, patients with autoimmune rheumatic diseases are at risk of infection and benefit from preventive strategies. Benefit most, there are actually people are trying to develop some scoring system, but still it is a long way to go. Vaccination should be ideally administered during the quiescent period. Non-live vaccines seem to be safe and sufficiently immunogenic when provided under most immunosuppressive therapies, except B-cell depletion therapy and probably abatacept. These are the references. Thank you for your patient care.
Thank you, Dr. Deep.
Who has ILDs, who are being for this B-cell depletion therapy, then those are patients who usually advise for immunotherapy. So actually, most important is when the patient was admitted for pneumonia once, those are the patients actually who accept vaccines actually more than the other patients.
Very true. Dr. Vijay Prasanna has cost is not a concern because she works in a government hospital. Let me ask her what opinion, how her practice is.
So basically we do vaccinate, especially pneumococcal vaccinations, but unfortunately this pneumococcal vaccination, except this, all other vaccines are available in my working area. But yes, we do vaccinate, especially for pneumococcal vaccines in patients of RA, particularly when they are being started on either a conventional demand initially or when they are planned for a biologic demand.
So how often do you use, especially JAK which I'm sure thousands of a lot of patients are on JAK. How commonly you see herpes zoster regarding the first talk? How commonly do you see?
Actually, if you see, so nowadays it is used so commonly, even by orthopedic surgeons, they are using as first line because then herpes zoster will be more like that. But I am not seeing that much actually as we fear that we see.
I think I have seen in my practice 5 or 6 cases of herpes zoster, but most of the herpes zoster are multi-dermatoma. So I think Shingrix vaccine may be a good addition to the armamentarium, especially in affordable patients who are more than 60 years, who are really fragile. In those patients, it may be a worthwhile option. So, yes.
Sir, I have a question. Sometimes when the patient presents with very active disease and it is imperative that we start immunosuppressive therapy right away, like in cases of vasculitis and all, when it is organ threatening. So in that cases, what you do? Because in B-cell therapy, when we are starting, we have to it is imperative that we vaccinate also.
But actually in those situations, actually vaccination won't come under the picture because that is a life-threatening disease. We have to treat the disease first.
So
we can think about, we can postpone the vaccination for
Let me just to give a clarity on that. See, as Pradeep said, in rheumatoid arthritis, we get time. We get couple of months, 1 month, 2 months. Then we can buy some time. For example, lupus patient, mycophenate, partial remission is achieved. So we want to boost the response. That time maybe we can wait for 1 month and vaccinate. By doing vaccinating, for example, COVID vaccine, we have done a lot of studies, one of which is published in IGR. What we have shown is that these patients who are on rituximab, if you give COVID vaccine, they do not mount humoral immunity, but they get cell-mediated immunity. So, and if you give a higher dose, 3rd dose or 4th dose, they also start producing some kind of antibodies. Especially somebody who has a B cells are detectable. So after 6 months, which happens around 6 to 8 months post the rituximab infusion, that time will be the best time to vaccinate. But having said that, how can you wait for 8 months? Sometimes it is not possible. Every 6 months you are going to get the results.
Say in SLA, severe SLA or vasculitis, you are planning for rituximab if you want to vaccinate. So after vaccination, you have to wait for another 1 month. I think in active disease that won't be possible.
That is not possible.
That won't be possible.
So once we do the induction therapy for 4 weeks, we give weekly rituximab, and then we wait
after
for
6 months. It is recommended that for rituximab after 6 months we can give vaccines.
That's what our study showed, that it's not 6 months what is important, it's basically the B cell repopulation is important. If it is more than 1 year, that's fine. But 6 months to 1 year, that period we are not sure of the B cell repopulation. Check the B cell levels by CD19 flow cytometry. That will be the ideal. But always we should remember that patient is going to develop pneumonia only when he is alive. So unless you give rituximab, patient may die. So basically for preventing a chance of pneumonia which is less than 1%, we cannot allow a mortality risk of 30%. So always in doubt, if your patient is in a dire situation, treat.
Thank you.
So,
just one comment. You see, when you ask the patient to get the 2 shots of pneumococcal vaccine, most of them run away. They don't take it. So what we do in our clinic, at least we give them 1. Maybe we give them the 23 one. We don't give them the Prevnar 30 because that's more expensive. I know it's not right, but that is the least we can do. At least cut down the rate of infection. I don't know what you people do. That's what we are trying to do, at least in our side.
But the efficacy of this conjugate vaccine gradually declines. That is the reason why we boosted with the polysaccharide vaccine at least 8 weeks from the conjugate.
I agree, but something is better than nothing. That's the problem.
so frankly speaking, sir, I'm just taking Vijay Prasanna. How commonly in my practice we have seen a culture-proven pneumococcal infection. It's very, very rare. I don't know why I'm not sure whether it's the same with everybody else.
Perhaps they don't come to us directly, they go to the internists. That could be another reason.
Yes. But influenza, I think influenza vaccine is very, very useful to cut down.
There's no problem with the influenza vaccine.
And one more point I want to add is the point to be well taken by Dr. Pradeep talk, that at what level of immunosuppressive therapy, at what dose of immunosuppressive therapy the live vaccines to be given. So the slide is very good and it should be well noted, especially with the postgraduates and all the practicing rheumatologists. That is a very important slide which Dr. Pradeep has focused.
If there are no more questions, I would like to thank both my co-chair and Dr. Pradeep and Dr. Subramanian who have joined. And thanks a lot for coming at this evening hour from 7 o'clock. All of you have been working very, very hard. Thank you everyone. Thank you all. And thank you GSK also for organizing this. And hope you bring the vaccine at an affordable cost to our patients.
Really makes it.